All right, let's jump right into this guide on burn assessment. We've designed this specifically for clinicians and nursing students, so we're going to break down the absolutely essential steps to evaluate a burn injury, from that first look all the way to calculating its size. This is a core skill you'll use your entire career, so let's get to it. Okay, so here's how we're going to tackle this. First, we'll cover that initial assessment, what you do the moment you see the patient. Then, we'll get into gauging the real severity, classifying the burn's depth, and calculating its size. And of course, we'll wrap up by putting your knowledge to the test with a real-world scenario. This flow is pretty much exactly how you'd approach a patient.
First up, the initial assessment. So you've just walked into the room, you see a patient with a burn. Your entire evaluation is immediately going to be built on 3 foundational pillars.
So to figure out just how bad this is, your brain needs to be asking 3 critical questions right away. How big is it? How deep does it go? And where on the body is it? Seriously, the answers to these 3 questions are going to shape everything that comes next, the patient's prognosis and our whole treatment plan.
Now, let's build on that, because a burn injury is never, ever just about the skin. To really understand how severe it is and what the likely outcome will be, you have to look beyond the wound itself.
The patient's age, the total body surface area that's been burned, and whether there is an inhalation injury, those are the 3 biggest factors that determine survival. But you also have to factor in things like pre-existing conditions, diabetes or heart disease, and how the burn happened. An electrical burn, for instance, is a completely different beast than a simple scald burn. It's a systemic event, not just a skin problem.
So thinking about that third pillar, location, let's pause for a quick clinical question. Just using your own reasoning, where on the body would it be particularly bad to get a burn? Think about daily function, complications, and cosmetic impact.
And yeah, if you were thinking about areas that are just crucial for function and a person's identity, you're exactly right. Burns on the hands, the face, or the genitalia are automatically considered severe. And then there's a special category, circumferential burns. That's a burn that goes all the way around a limb or the torso, and trust me, that poses a unique and very immediate threat.
All right, now let's get into the real nitty-gritty of classification, understanding the depth of the injury. We break this down into 4 degrees, and each one tells you something different about which layers of tissue have been damaged. This slide is great because it really connects the dots for you. It visually maps our clinical classifications directly onto the anatomy. You can see really clearly how a 1st-degree burn just skims the surface, the epidermis, while a 4th-degree burn can go all the way down to the bone.
Let's start with 1st-degree or superficial burns. The easiest way to think about this, a classic sunburn. It's red, it hurts, but it's only affecting that very top layer of skin. These almost always heal up on their own in about a week, no scarring.
Okay, 2nd-degree burns. This is where it gets a little more complex, because we actually split them into 2 different categories. A superficial partial thickness burn is going to be bright red. It'll be wet, you'll see blisters, and it's going to be extremely painful. But a deep partial thickness burn, that's going to look different. It might be red but with patchy white areas, it'll be drier, no blisters, and, this is the weird part, it's actually less painful.
So that brings us to a quick quiz, just to make sure this concept really sticks. Why on earth would a deeper, more severe 2nd-degree burn actually hurt less than a more superficial one?
And the answer is nerve damage. It's that simple. In those deeper burns, the nerve endings themselves have been damaged or completely destroyed. That's why the patient reports less pain, and it's a huge diagnostic clue for you. Next up, 3rd-degree burns, also known as full thickness. Now we're talking about destruction of all the layers: epidermis, dermis, and even the subcutaneous fat. The key signs to look for here are a painless wound because all the nerves are gone, and skin that looks leathery, dry, and totally inelastic. These will not heal on their own. They always require skin grafts. Okay, let's circle back to that idea of a circumferential burn we mentioned earlier. What is the major limb-threatening complication you absolutely need to be watching for when a 3rd-degree burn wraps all the way around an arm or a leg? The answer is a big one: compartment syndrome. This is a true emergency. That tough, leathery burn tissue, we call it a scar. It basically acts like a tourniquet. As all the tissue underneath starts to swell from the injury, the pressure builds up, and it can completely cut off blood flow to the limb. So how do you spot this? You have to know the 6 Ps. This is your critical checklist. It starts with pain that is way out of proportion to what you'd expect, then a feeling of intense pressure, As it gets worse, the patient will get paresthesia, that pins and needles feeling. Then you'll see pallor or pale skin. And the really late, really bad signs are pulselessness and paralysis. You have got to catch it before you get to those last two.
And this picture just illustrates it perfectly, right? All that swelling from the body's inflammatory response literally has nowhere to go. It's trapped by that tough, burned tissue, so it presses inwards, squeezing the blood vessels and nerves and just choking off the limb's circulation.
Okay, so we've covered location and depth. Now let's get to the final piece of our initial assessment, the numbers game. We're talking about calculating the size of the burn or the total body surface area. In an emergency situation, the fastest way to get this done for an adult is the rule of nines. It's a beautifully simple method that divides the body surface area into sections of 9% or multiples of 9. This gives us that quick estimate we need to start one of the most important interventions there is, calculating fluid resuscitation.
So here's how it breaks down. The entire head and neck, that's 9%. Each full arm, from your shoulder all the way to your fingertips, is another 9%. The torso is split, 18% for the front, 18% for the back. Each full leg is 18%, and the general area makes up that last 1%. It's a really slick way to quickly map out the burn and get a total percentage.
All right, time to put it all together. You've seen the theory, now let's run through a quick practice scenario so you can apply the rule of nines yourself.
Okay, here's the situation. Your patient has second-degree burns covering their entire anterior torso, so that's their chest and their abdomen. They also have a mix of second and third-degree burns on their entire right leg. Go ahead, take a second, use the rule of nines, and calculate the TBSA. Got your number? If you calculated 36%, you nailed it. The anterior torso is 18%, and the entire right leg is another 18%. You add them together, and you've got a 36% TBSA burn.
So, you've done it. You've assessed the depth, the location, and the size of the burn. You've got your TBSA percentage. You've mastered that critical first step. But this is just the beginning, isn't it? The real question now is, what comes next? This assessment is the foundation for everything that follows, from massive fluid resuscitation to complex wound care.